Today we're looking at the internal electrical conducting system of the heart. And to help us, I've just sketched out a heart here. But before we look at this, it's interesting to think about patients with heart transplants. Now, if someone donates a heart, the heart is taken out of their thoracic cavity. And if you think about it, that's going to sever all of the nerve connections that would connect to that heart. And then when it's placed into the recipient, the heart will keep beating, hopefully for years or decades, without any external neuronal innervation. So this tells us that the impulse to stimulate cardiac contraction must be intrinsic to the heart itself. It's actually in the heart itself. And we want to explain this using this simplified model of the heart. So here we have the left side, left atrium, left ventricle. That means that that valve there pointing down the way is the mitral valve. This is the aortic valve, and this is the aorta leaving the left ventricle of the heart. Here we see the right atrium. This represents the inferior and superior vena cava. The right atrium, the right ventricle. That means this valve pointing down the way must be the tricuspid valve. And this is the pulmonary arterial, sometimes called pulmonary arterial semilunar valve, guarding the entrance of the pulmonary artery, dividing to each lung. The top part here is the base of the heart, and the bottom pointed part is called the cardiac apex. And this vessel here represents the 4 pulmonary veins. So all round about the heart we have the myocardium. So there's going to be atrial myocardium up here. The myocardium, of course, being the contractile muscle of the heart, the middle layer. Round about the outside there's the pericardium. On the inside there's the endocardium. And here we're thinking about the myocardium. So this is the ventricular myocardium here. Now the myocardium extends up into the cardiac septum and of course round the wall of the right ventricle. Now what has to happen in a cardiac cycle is we need the atria to contract first, pushing the blood from the atrial chambers through the atrioventricular valves into the ventricles. That has to happen first in a coordinated way. Then, at an appropriate, very short period of time, but just the right period of time after that, the ventricles need to contract. Now, I think you can see that if the ventricles contracted from the top down the way, the blood would just go down here, which wouldn't be much use at all. So we need the ventricles to contract from the bottom up, forcing the blood towards the arterial valves, the aortic arterial valve and the pulmonary arterial valve, sometimes called the semilunar valves, so the blood can go away via the aorta into all of the systemic circulation and via the pulmonary artery into the pulmonary circulation to be oxygenated. So this whole thing needs to be precisely coordinated and regulated. So how is this achieved? Well, just in the right atrium, somewhat near the entrance of the superior vena cava, there's an area of specialised myocardial tissue. This is not nervous tissue, it is myocardial tissue, but it's specialised to be electrically active. And this is called the pacemaker of the heart, or the sinoatrial node. So this is the sinoatrial node of the heart, the SA node, sinoatrial node. And this is what generates the sinus rhythm, the normal rhythm of the heart. So there's the sinoatrial node here, specialised myocardial tissue, electrically active. And this area is what we call intrinsically unstable. It is electrically intrinsically unstable. So quite spontaneously, all on its own, without anyone telling it what to do, without any hormonal influence, without any neurological influence, this will depolarize. And it will depolarize spontaneously at round about 90 times a minute, sometimes 90 to 100 times a minute. It will depolarize, thereby generating a new electrical nerve impulse. So this node will just keep depolarizing 90 to 100 times per minute, generating a new electrical activity. And this is the focus that's controlling the electrical activity of the heart. Now, there are other electrically active areas in the heart. For example, there's an area here, and that's a node between the atria and the ventricles. So that's called the AV node. The atrioventricular node between the atria and the ventricles. And that's also electrically active, but the spontaneous depolarization rate is lower than the sinoatrial node. So it's the sinoatrial node which governs the other electrical active tissues. And in fact, even the individual myocardial cells themselves will spontaneously depolarize, but at a lower rate. So because the sinoatrial node is depolarizing the fastest, that is the origin, the physiological origin of the electrical activity required to stimulate the myocardial cells in order to generate myocardial contraction. Now, what do we need to contract first? Well, it's the atria that need to contract first. So coming from the sinoatrial node, there are conducting pathways, preferential conducting pathways, carrying the electrical impulse to different parts of the atrium. And most physiologists now agree there are three preferential pathways. Specialized tissue which conducts the electrical activity freely. And we have the posterior, the middle, and the anterior pathway. And this anterior pathway also takes impulses across to the left atrium. And as these tracks go through the atrial areas, smaller branches come off them, and these take the electrical activity to the atrial myocardial cells. That depolarizes the atrial myocardial cells, and it is that depolarization that tells them to contract. So they will contract when electrically stimulated. So the electrical activity is generated in the sinoatrial node, rapidly goes through these tracks, these conducting pathways, to take the impulse to the atria, to the atrial myocardium. When that depolarizes, it contracts, and that is what causes the atrium to contract down the way, ejecting the blood from the atria down to the ventricles. And these pathways converge at this node here, which you might remember as the AV or the atrioventricular node. And it's useful sometimes to describe this as a collecting node. It collects the impulse from the atria. And now we notice that there's a sinoatrial node there and an atrioventricular node there. So these pathways here can be referred to as the internodal tracks. The internodal tracks. The conducting tracks or the conducting pathways between the two nodes. And this collects the impulse. Now we notice that the valves are more or less on a plane across the middle of the heart. And the valves are made of fibrous tissue, they're largely collagen. So what we end up with is a ring, an atrioventricular ring of fibrous tissue in this valvular plane. So we have fibrous tissue in an atrioventricular ring separating the atrial chambers from the ventricular chambers, from the ventricles. And the fibrous tissue does not conduct electricity. And of course this is remarkably useful. As well as being tough fibrous tissue for the valves, the same tissue is electrically insulating. So the impulse that gets into the atrial myocardium will cause the atria to contract, but then it will stop at the valvular atrioventricular ring. So the impulse can't get from here down to here, or from here down to here, or from here to here. There is a layer, an atrioventricular ring, that is electrically resistant. The only way the electrical impulse can get from the atria down to the ventricles in the physiological healthy situation is via the atrioventricular node. So this collects the impulse. And this impulse, the same impulse that was generated there, has gone through the internodal tracts. It's caused atrial myocardial depolarization, and it's collected by the atrioventricular node. It's a collecting node. And of course, remember, we want the heart to contract basically from the bottom up, the bottom being the cardiac apex. Now, what actually happens is, as the impulse is going through this node, it's delayed by about 40 milliseconds, something under a 20th of a second. But that delay is important because during that delay, as the impulse goes through the atrioventricular node slowly, that gives the blood mechanically time to get through from the atria to the ventricles. So once the atria is contracted, we need these 40 milliseconds or so to give the blood time to get from there to there. And that means that the ventricles fill up with blood prior to ventricular contraction or prior to ventricular systole. Now, if we want the impulses more or less to start going into the ventricular myocardium down here, we need to get them down there quickly. So first of all, we have a bundle of tissue here which will conduct the electrical impulse that's been collected by the AV node, and it will start transmitting that impulse down through the cardiac septum. And the impulse here is transmitted very quickly. And this is called the atrioventricular bundle, or in the old days we used to call it the bundle of His, presumably after the guy that discovered it. But these days we normally call that the AV bundle or the atrioventricular bundle, taking the impulse down the way. And then this quickly divides into two smaller bundles, and these bundles start bringing the impulse further down through the cardiac septum. This one actually branches, taking the impulse into the higher parts of the ventricular myocardium. There's actually a few branches here, but there's two main ones, the left bundle branch and the right bundle branch. And this is going to go on down here, taking the impulse down towards the cardiac apex. And likewise with the right bundle branch coming down here. Again, there's going to be some branches off it, going to different parts of the right ventricular myocardium, and it's going to go down here towards the cardiac apex. So what we see now is the bulk of the impulse that's been picked up by the atrioventricular node, rapidly transmitted down through the atrioventricular bundle of His into the left and the right bundle branch, has been transmitted down towards the cardiac apex. And at the cardiac apex, smaller fibres start taking the impulse into the ventricular myocardium. And these smaller fibres are called the Purkinje. The Purkinje fibres. Now, we don't normally in anatomy these days use the names of people that discovered things, but all the textbooks still seem to call these fibres the Purkinje fibres. But what they are is they are small areas, again, of specialised myocardium, designed specifically for electrical contraction, for electrical conduction rather, not contraction. And these will conduct the electrical activity rapidly towards the contractile myocytes. So all this tissue I've drawn in red is myocardium, yes, but it's myocardium which is designed for electrical activity and conduction rather than contraction. So the Purkinje fibres, specialised myocardial cells designed for electrical activity and conduction, taking the electrical impulse towards the contractile myocardial myocytes, causing them to depolarise, and of course when they depolarise they will contract. And the impulse is then carried further up to all parts of the ventricular myocardium on both sides. So what we see is the electrical activity is basically going into the myocardium here, causing the depolarization here, giving us almost a wave of contraction going up the way like that, brilliantly directing all the blood to the bullseye, if you like, to the target of the aortic and pulmonary valve, ejecting the blood into the systemic and the pulmonary circulation. And all these fibres, all these electrical fibres, the bundle branches and the Purkinje fibres, are going into the bundles of myocardial cells. And we now know that the myocardial fibres are arranged in particular patterns around the heart, because what we want is we want these chambers to contract, but also the septum will shorten and go up the way. So the chambers contract and it goes up the way. So can you see that's compressing the blood in the ventricles in two ways? It's squeezing in that way and squeezing up that way. That will increase the pressure of the blood in the ventricles. That will shut the atrioventricular valves, preventing regurgitation of blood back into the atria. At the same time, the increase in pressure in the ventricles will open the arterial valves, allowing the blood to go up out of the ventricles into the arterial system without regurgitation. So we've got the electrical activity, the myocardial activity, and the valvular anatomy and physiology all beautifully coordinated. And as well as going that way and up the way, the heart actually twists as well. When the heart contracts, it twists. It's a bit like wringing your washing out. You can twist it. And as it twists, that also increases the pressure and ejects blood out of the arteries. And as it twists, it also stores some energy. And once the cardiac contraction is over, once the ventricular systole is over, that potential energy is released and springs the heart back into its resting anatomical position. And that helps ventricular filling as well. So we've got the contraction, the up the way and the twisting, all coordinated by these electrical, this electrical internal conducting system. Now, it's fairly obvious that the heart rate can vary. So the heart will keep going at 90 to 100 beats per minute. But if you look at your heart rate, it's probably less than that. And what we have coming down here is we have one of the large nerves in the body, the vagus nerve. The vagus nerve is the 10th cranial nerve. It's the main parasympathetic nerve in the body. And branches from the vagus nerve will go off to the sinoatrial node, and branches from the vagus nerve will also go off to the atrioventricular node. So if you're fairly fit at the moment, your heart rate might be 60. If you're very fit, it might be 50. If you're athletically fit, it could be even lower than that. And the reason that your heart rate is not obeying the intrinsic rate of depolarization determined by the sinoatrial node is the parasympathetic innervation of the vagus nerve, the 10th cranial nerve, which is slowing that down. So what you find is, as we started this talk thinking about people with heart transplants, when you take the heart out, you're going to cut the nervous connections. What you normally find is after a heart transplant, the recipient has a heart rate of 90 to 100 beats per minute, which is exactly what you would expect as a result of the physiological waves of depolarization generated by the sinoatrial node without the parasympathetic vagal inhibition. And that's what we see. Now, people who've had heart transplants aren't very good at jumping up and doing sudden exercise, but if they start walking and then walk faster, they can even end up jogging or running, because over minutes the heart can be stimulated via endocrine influences as well. So the heart rate is stimulated by these, well, the heart rate is generated by the sinoatrial node. It's inhibited by the parasympathetic, but it can be stimulated by hormones as well, such as adrenaline or epinephrine, of course, springs to mind, that will increase heart rate. And also the heart rate can be increased by sympathetic activity. So in the same way that there are parasympathetic fibres going to the sinoatrial and atrioventricular node, there's also going to be sympathetic fibres. And of course the sympathetic fibres will increase the rate of contraction and increase the strength of the contraction as well. So the heart has this intrinsic rate, but it can be lowered by parasympathetic activity, and it can be increased by sympathetic activity. But still, we need to learn these main bits: sinoatrial node, internodal tracts, atrioventricular node, bundle of His or atrioventricular bundle, left bundle branch, right bundle branch, Purkinje fibres going into and coordinating the contraction with exactly the right amount of delay of ventricular contraction after the atria have contracted. So there we have the internal electrical conducting system of the heart, controlling and coordinating cardiac myocardial contraction.